هلا بينت ايه
اي واضح
مظبوط اوكي. طيب لما بدكم نبلش قولوا لي.
اوكي على 2 كلوك دكتور.
هلا شايفين سكرين ايه؟
واضح جدا.
اوكي لما بدكم قولوا لي. اليوم ما لها في بارتيسيبنتس كثير.
لسه يا دكتور يخشوا الساعه 2.
بعد
الاعلان على الساعه
بكير. طيب
الاعلان على
ننطر بعد شان. اوكي. Okay, we will be discussing today the following list of topics, which will be a continuation of the sport injuries that was started 2 sessions ago. The knee, we'll start with the knee. A bit about the anatomy. The osseous anatomy of the knee consists of the proximal tibia, the distal femur, and the patella. The distal femur consists of the medial and lateral condyles, as I am sure everybody knows. Above each are the medial and lateral epicondyles. These structures are important for localization of the amount of rotation that we follow in the insertion of a total knee. In addition, we have the femoral trochlear groove and the intercondylar notch. These are the structures marked above each: the medial, the lateral femoral condyle, the intercondylar notch. You have the patella undersurface. In the patella fossa, which is an important area, which tells us a lot about subluxation or dislocation of the patella. We have the intercondylar eminences on which the menisci attach to, and they are surrounded by the meniscus. And you have Gerdes tubercle. We know Gerdes tubercle is very important as a sign. If we have a fracture in the area, we usually suspect a ACL injury following a sporty-ish injury. All these structures are important, and you have to keep them in mind because they are landmarks to several radiologic appearances as we are doing measurements for correction of deformities of the knee. You should also know about the femoral mechanical axis, which is a line passing from the center of the hip to the center of the knee to the area in the central area of the ankle or tibial plafond. Also, you should know about the anatomic axis, which is a longitudinal line passing through the femur and one through the center of the tibia, and where they intersect, they give you the proper measurement of the angle. You should know about the muscles that surround the knee. It's very important that you know which muscles are involved in extension, what is their nerve supply, and which are involved in flexion. And these are the dynamic stabilizers of the knee. We know we have static stabilizers that I will be discussing, and the dynamic stabilizers. This tells you further about the anterior cruciate ligament, which extends from the lateral medial aspect of the lateral femoral condyle to the anterior tibial eminence. And we have the posterior cruciate ligament, which extends from the posterior aspect of the upper end of the tibia to the lateral aspect of the medial femoral condyle. So you have to pay attention to these. The anterior cruciate extends from the medial aspect of the lateral femoral condyle, and the posterior cruciate is from the medial aspect of the medial femoral condyle. So they're opposite each other in a cross fashion, and they are tight. They can be tight in extension and more or less tight in flexion. So how can we examine them? You have to relax the collateral ligaments by flexing the knee and stressing them. This we will talk later on. The medial condyle is the larger condyle and extends slightly distal compared to the lateral femoral condyle. And this is what gives us the slightly valgus position of the knee. Both condyles are covered with articular cartilage. The trochlear groove lies on the anterior aspect of the distal femur between the medial and lateral femoral condyles. So this surface is also covered by the articular cartilage and serves as the site of articulation of the patella. And as I mentioned previously, this area, this fossa area on which the patella glides is an important structure. It can be shallow, it can be deep. If it's shallow, you get subluxation, and we have several conditions which are related to subluxation and dislocation of the patella. The lateral rim of the trochlear groove is frequently more prominent than the medial side to allow for proper patella tracking along the femur. So this is what you should realize. The epicondyles serve as the site of insertion of several important structures. The deep and superficial collateral ligaments, the MCL, attached to the medial epicondyle. We have a deep one, which takes part in the stress between the distal femur and the proximal tibia. This deep one is attached to the meniscus. We have a superficial portion of the medial collateral ligament extends distally along the medial aspect of the tibia in the pes and theranis with the semitendinosus, the sartorius, and the gracilis muscles, forming these four components that form or take part in stabilization of the knee joint medially. The proximal margin of the medial epicondyle is enlarged and serves as the site of insertion of the adductor magnus, namely the adductor tubercle. The lateral or fibular collateral ligament attaches to the lateral epicondyle. Inferior to the attachment of the lateral collateral ligament is the insertion of the popliteus muscle at the junction of the lateral condyle and epicondyle. The medial and lateral heads of the gastrocnemius muscle originate from the medial and lateral posterior femoral condyles. These structures all surround the knee. These structures all give dynamic stability to the knee. The intercondylar notch is the site of femoral attachment of the cruciate ligaments. As I mentioned, they are the anterior and posterior intercondyle spinous processes that are located over there. The anterior cruciate ligament attaches to the posterior lateral aspect of the notch, and the posterior cruciate ligament attaches in the anterior medial aspect of the notch. So on the floor or the tibial plateau, you have the intercondylar eminences. In between both condyles, you have the notch. And in between them lies two crossed significant ligaments of the knee. One attached to one condyle and the other is attached to the other condyle. And it's crossed like an X. The proximal tibial surface, as I mentioned, is composed of the medial and lateral plateaus, and on them lies the intercondylar eminence. The medial plateau is larger and extends further posterior compared to the lateral plateau. You should know these things. Which is the larger? Which condyle extends more distally? Which one is larger? You should know where the cruciate ligaments attach or originate from, and you should know about their function. These are the basics of the knee joint. On them depends a good amount of stability. The surface of the medial plateau is slightly concave. The lateral tibial plateau is slightly convex. Please keep this in mind. Both of the tibial plateaus are covered with articular cartilage. The intercondylar eminence is the site of attachment of menisci and the cruciate ligaments. The menisci embrace the intercondylar eminence. The patella is a large sesamoid bone within the tendon of the quadriceps mechanism. It is the largest sesamoid bone. There are two major facets on the patella. You have the medial and you have the lateral facet. There is significant variability in the size and orientation of these facets. Normally, the lateral facet is broader and the medial facet is more acutely oriented to the femoral trochila. This shows you the broader lateral facet, and you have the medial facet is more angulated. It forms a complete or vertical angle. You have a ridge in between the two, and the patella is divided into portions, the superior or the inferior or apical portion. So the larger facet is the lateral. And as far as we are concerned, it's more important than the medial facet. We will see this later. The osseous anatomy of the knee provides little to stability of the knee. Stability and function are therefore provided by the complex soft tissue envelope around in the knee. The soft tissue components of the knee can be divided into several components. You have to look at them. Look at this. You're looking vertically or in line with the shaft of the tibia directly over the plateau. You see two menisci. You see one is broader but thinner than the other. The lateral meniscus is thicker and shorter. The medial meniscus is broader and more wedge-shaped. The menisci are attached by means of ligaments. On the medial side, you have the attachment directly to the capsule. It is more fixed, more rigid than that of the lateral, which is not attached fully. It's also perforated by the popliteus tendon. And during motion, the lateral meniscus moves more freely than the medial meniscus. This shows it further. You can see the coronary attachment of the meniscus to the capsule on the medial side. Look at the lateral side. The meniscus is thicker and they are made up of cartilage. You should pay attention that adjacent to the posterolateral aspect of the lateral meniscus, you have the popliteus tendon, which is perforating this area. You have to know this and know its relation with the fibular collateral ligament. When you're doing a total knee, you have to know all this anatomy, or else don't do it. I put this slide up because it gives us an idea of how the popliteus tendon perforates the capsule in line with the lateral meniscus and inserts onto the posterior aspect of the tibia medially. You should see the coronary ligaments attaching to the meniscus. These nearly fix the ligament to the tibial plateau. There is little movement of the medial meniscus over the tibial plateau. The lateral meniscus is more lax. In addition, you have two posterior meniscal ligaments. These are the ligament of Risberg in relation to the lateral meniscus and the ligament of Humphrey. So let us speak about the static restraints or ligaments. And you have the dynamic restraints, which are the muscles and the tendons and the menisci. The static restraints are represented by the medial collateral ligament, the lateral collateral ligament, the anterior cruciate, and the posterior cruciate ligaments. These give us static stability of the tibia with respect to the femur. If these are cut, then you will have instability. These structures resist valgus and varus stress, as well as anterior and posterior translation of the tibial relative to the femur. The MCL, as I mentioned before, consists of two layers. The deep MCL spans from the medial epicondyles of the femur to the proximal tibial border. It's attached to bone directly along the borders of the joint. It's just medial to the tibial plateau. This shows you the deep medial collateral ligament attached to the medial meniscus of that is on the upper margin of the tibial plateau. If you look at the slide on the right-hand side, it tells you more about the medial collateral ligament, and it tells you about the superficial portion of the medial collateral ligament. The superficial medial collateral ligament has the same femoral origin. However, the ligament has a broad tibial insertion, as I mentioned before. It extends 6 to 10 centimeters below the tibial plateau, along the posterior medial border of the tibia. The lateral collateral ligament is a more discrete band along the lateral aspect of the knee. It spans from its origin on the lateral femoral epicondyle and inserting on the proximal tibia, instead of inserting on the proximal tibia, it inserts on the fibula. Sorry, I apologize. The ACL resists the anterior translation of the tibia relative to the femur. The ligament runs from the anterior aspect of the tibial eminence to the posterior lateral aspect of the posterior of the femoral notch. The PCL resists posterior translation of the tibia relative to the femur and resists hyperextension of the knee. The ligament, the PCL, extends from the posterior aspect of the intercondylar eminence and proximal tibia in the midline to the anterior medial aspect of the femoral intercondylar notch. The dynamic restraints in the knee are the muscles and tendons, and these all cross the knee joint. These are broadly divided into muscles which act to extend and those which act to flex the knee. The extensor muscles are the quadriceps femoris and the tensor fascia lata. The quadriceps is a group of 4 muscles. Remember these. You will live on them, and we come across them every day. These are all inserting onto the patella and patella tendon, which in turn inserts upon the anterior tibial tubercle. The muscles that make up the quadriceps are the rectus femoris, the vastus lateralis, the vastus medialis, and the vastus intermedius. Remember them. The rectus femoris, vastus lateralis, vastus medialis, and vastus intermedius. These are all supplied by the femoral nerve. Remember this. The tensor fascia lata originates upon the pelvic brim and inserts at Gerdy's tubercle, just in front of the proximal fibula, on the proximal anterior lateral aspect of the tibia. The tensor fasciae lata is innervated by the superior gluteal nerve. So remember, out of the extensors, the only muscle which is supplied by the superior gluteal nerve is the tensor fasciae lata, while the rest are supplied by the femoral nerve. Don't forget this. In exams, we ask this. These are the muscles. From the front, you have the quadriceps, which are the rectus femoris, the vastus lateralis, the vastus intermedius, and the vastus medialis. Don't forget them. From behind, you have the hamstring muscles, which I will be discussing soon. And from the front, on the lateral aspect, don't forget the tensor fasciae lata. The tensor fasciae lata, the origin is the anterior superior iliac spine. The insertion is onto the iliotibial band. The action, it abducts and helps stabilize and steady the hip and knee joints by putting tension on the iliotibial band of fascia. Innervation, as I mentioned previously, is the superior gluteal nerve. It comes or receives branches from L4, 5, and S1. The primary flexors of the knee are the hamstring muscles, namely the semimembranosus, tendinosus, and biceps femoris, and sartorius, and not forgetting the gracilis. The hamstring muscles originate on the ischium and insert on the posterior medial and lateral proximal tibia. Now, I would like to mention, when we speak about two joint muscles, these are muscles that originate or bypass two joints, and these are the hamstrings. Also, we have muscles on the anterior aspect. Don't forget about the biceps femoris, the rectus femoris. All these can biceps, the sartorius. You should not forget these. These are the two joint muscles. And when you do an osteotomy of the femur and you shorten the femur, you see that these muscles will relax and it will allow you to work on the area much more easier than if the bone was intact and up to its original length. So you have the gluteus maximus from behind, you have the adductor magnus, you have the semimembranosus, the biceps femoris, the gracilis, and semidendinosus. These are two joint muscles, except for the gluteus maximus and the adductor magnus. The rest, the hamstrings, the semitendinosus, semimembranosus, biceps femoris, gracilis are all two joint muscles arising above the hip and inserting below the knee. They receive their innervation from the sciatic nerve. All are innervated by the tibial division of the sciatic nerve, except for one. The short head of the biceps is supplied by the peroneal division. So for this reason, we enjoy it. From where, what is the nerve supply arising only, what muscle is the nerve supply arises from the peroneal nerve only. And you have to mention the others arising from the tibial portion, while the peroneal portion only supplies the short head of the biceps. The sartorius originates from the anterior superior iliac spine, and this is the tendon that often we detach or reattach or whatever you want to call it when we're doing a Salter osteotomy to get the exposure and do your iliac osteotomy and obtain bone to put throughout the open wedge that we create when we're doing a Salter osteotomy. Now, both of these muscles with the semitendinosus insert into the proximal medial tibia in the pes and serine goose foot, relating to the parents of the three tendons inserting together. The sartorius is innervated by the femoral nerve, and the gracilis is innervated by the obturator nerve. I know it's quite hectic to know all these supplies, but you should know them. You should know them. When you graduate or you specialize, then you're free to know or not to know. But it is always preferable to know your anatomy well. This slide shows you the sartorius of how it's coming to join the semitendinosus and the gracilis to form the pes and serinus, together with the superficial portion of the capsule of the medial collateral ligament. The other muscles that serve to flex the knee are the gastrocnemius and the popliteus muscle, which I spoke to you of how it arises and passes through the capsule behind the posterolateral aspect of the lateral meniscus and inserts on the proximal medial aspect of the tibia. The gastrocnemius, a large muscle extending into the Achilles tendon, and it joins with the soleus tendon. It has two origins from each condyle. And this inserts into the calcaneus. This shows you the gastrocnemius arising from both condyles and inserting through the Achilles tendon onto. You have a group of three tendons, which are the tibialis postatus, the digitorum, and the flexor hallucis longus, which is most medial. So please know your anatomy well. Know the popliteus tendons. You should know that it arises from the epicondyle and inserts on the medial, the lateral epicondyle of the femur, and perforates the capsule behind the posterolateral aspect of the lateral meniscus and inserts on the proximal medial aspect of the proximal tibia. The menisci are two crescent-shaped cartilaginous structures attached to the proximal tibial surface. These structures serve two purposes in the knee. They increase surface area for weight bearing, therefore reducing the peak stress on the articular cartilage. These are the menisci. You see, they are described as, you see, if you put the surface of the proximal tibia directly on the femur, you see that there is totally an irregular space. And with this irregularity, it will cause degeneration and destruction. The menisci are soft structures that lie in between the tibial plateau and the distal femoral condyles. They fill in the empty space and they increase the surface area and allows throughout a well distribution of synovial fluid for nutrition of the cartilage. They also provide a small degree of stability to the knee by changing the relatively flat tibial articular surface to a cupped surface. The menisci are composed of dense, organized cartilage tissue. So much for anatomy. Biomechanics of the knee. The mechanical axis of the lower extremity extends from the center of rotation of the hip, center of the ankle joint. This only crosses the knee joint in the lateral third of the medial tibial plateau. The lateral third. We know that the medial tibial plateau is that area. The lateral third, not totally in the center. The normal anatomic alignment of the knee is 5 to 7 degrees of valgus. This, I come back to it. You see, the line is passing in the lateral third and into the center of the tibial plafond. When the knee is loaded, the medial compartment receives 60% of the weight-bearing stress, and the lateral compartment receives 40% of the weight-bearing stress.
دكتور جون. اوكي شباب، المحاضرة توقفت عند الدكتور جون دقائق ونعود اليها.
جماعة؟
ايوه واضح.
Okay. So Let me see, maybe I'll go back one slide. So patients with significant angular deformity of the knee will have altered weight bearing, resulting in increased stress in the medial with varus or bow-leg, or lateral with valgus or neck. Increased stress will frequently result in early arthritis in the overused compartment of the knee. The highest joint forces, however, are found in the patellofemoral articulation, as articulation can be noted for activities such as stair climbing and jumping. Looking at this slide is enough to tell you how important is the patella. The patella provides a good amount of forces to the knee joint. Trying to get rid of it. Okay. Okay. Now, look over here. You have the quadriceps, which is in line with the patella down to its insertion. You have the vastus medialis. You have the medial patella retinacular fibers. All these, together with the tibial band, are all producing bowstringing force on the patella. And كلهم يلي surrounding the patella are producing a force in position, and it produces a force to allow extension of the knee. The function of the patella is to provide a mechanical advantage to the quadriceps tendon. The patella moves the line of pull of the quadriceps further away from the center of rotation. Therefore, it acts as a lever and reducing the force required to extend the knee. Keep this in mind. The patella has a very important function, and it is for this reason we try to save the patella in any possible way. Patients who have had the patella removed because of arthritis or trauma are noted to have approximately 30% reduction in the force in the quadriceps compared to patients with a patella. Evaluation of the painful knee. The history should begin with the chief complaint and how long the patient has noticed the problem. The specific look of the pain should be entered. You should know more about what is it the stabbing pain and any exacerbating or ameliorating factors. of the pain, activity, and rest is important to note in particular. Pain in the musculoskeletal pain that present at rest suggests a septic process or neoplasm, which may be primary or metastatic. Frequently, knee problems begin with the injury can be very helpful in determining the structures that are injured. The nature of any external force contacting the knee and the position of the knee at the time of injury should be elicited. Did an audible or palpable pop occur at the time of the injury? Shifting or abnormal movement of the knee may also have been noted at the time of injury. The degree and nature of any swelling around the knee are important to record. In addition to the description of injury, it is helpful to inquire about the patient's ability to use the knee after the injury. Was the patient able to weight bear? Was the onset of pain or swelling immediate or delayed? Could the patient flex or extend the knee after injury? Are important questions to ask the patient after knee injury. In addition to pain, patients with knee problems will complain of mechanical problems in the knee. Patients may note an inability to fully bend or straighten the knee. This is referred to as locking of the knee. We all know about locking, but you should be able always to give a differential diagnosis of locking. What is the cause? Could it be blood in the knee that's blocking it? Could it be a loose fragment? Could it be a fragment of the meniscus causing locking? You have to organize your thoughts. Locking can be the result of a loose body, as I mentioned, in the knee. It becomes lodged between the femoral condyle and tibial plateau, similar to a wedged door stop. مثل هيدي اللي بتحطها تحت الباب. It locks it. It prevents it from moving. The patients who note intermittent locking of the knee will usually be able to relieve the locked knee by gently moving the knee without weight bearing. You can kick your knee, kick it in there. It might unlock your knee. So you have a patient like this on the field, having injured his knee, having torn his meniscus, having obtained a fragment from the condyles, with the knee locked, and he suffers from pain. This maneuver allows the loose fragment to be released from between the femur and tibia, and motion will be restored. However, inability to fully flex and extend the knee can also be noted in patients with large effusions and in patients with ligament injuries. So you should put a differential diagnosis in your mind. And by doing this, you would miss much less conditions. Instability is another frequent complaint of patients with knee injuries. Patients will observe that their knee will shift or buckle with particular activities. Instability can result from two general etiologies. The first is ligamentous injuries. As noted previously, the stability of the knee is a result of the ligaments which cross from the tibia to the femur. Disruption of the ligaments will result in alteration of knee function. The knee may shift or sublux with activity. The second common cause of knee buckling or giving way is problems in the patellofemoral joint. Instability of the patella in the trochlear groove will result in a giving way sensation as the patella subluxes. Damage to the articular surfaces of the patella on or the trochlear groove will result in pain as the patella tracks over the trochlea. This skyline or sunrise or whatever view of the patella shows how important the lateral facet is with respect to the shorter medial facet, and of how you have an instability of the ligaments and of how the patella is moving outward as it is undergoing tracking. This can occasionally lead to a sharp, acute pain, which will lead to quadriceps releasing its contraction while the patient is weight-bearing on the leg as a result of a primitive reflex arc. The patient will note a giving way or buckling sensation in the knee, and a few patients may actually fall as a result of this. I think this is a very important slide. The majority of knee complaints are aggravated by activities. The specific problems the patient has encountered are important to know. Patients will commonly have difficulty ascending and descending stairs. Frequently, descending stairs will be the most symptomatic as this places a high stress across the patellofemoral joint. Bicycling can also aggravate the patellofemoral joint. Activities that involve quadriceps contraction with the knee inflection may result in subluxation in patients with patellar instability. Patients with meniscal tears will have difficulty squatting and may notice the snapping or pain when rising from a chair or ascending stairs. Activities that involve stopping and turning or cutting will result in knee shifting or giving way if there is insufficiency in the collateral or cruciate ligaments. Physical examination is the most important. Be patient. Observe and listen is the best policy to obtaining a proper diagnosis. Physical examination of the patient with a knee complaint begins by inspection, observation of the alignment of the lower extremity should demonstrate a normal 5 to 7 degrees valgus knock-knee angle at the knee when a patient is standing. So you should undress the patient completely. Leave him with a short so that you can see the positions of the knee, so that you can see the locking position. It will give you an idea. If the patient is dressed, you cannot see anything and you can miss the diagnosis. Deformity of the leg, varus or valgus, beyond the normal 5 to 7 degrees, can be associated with either a ligamentous or osseous deficiency. Any swelling, bruising, or ecchymosis should be recorded. Next, the evaluation should focus on the patient's gait. Normal gait requires the range of motion from 0 to 65 degrees of flexion. The gait should have a smooth cadence with the length of each step being equal on the left and right sides. The knee should not demonstrate any sudden shift to either the lateral or medial side. If abnormal lateral motion is noted, this is recorded as a medial or lateral thrust, respectively. If you observe the patient while walking and you see as the patient has a posterolateral deficiency and weakness, he has to thrust his leg laterally to compensate for this weakness. This is what we call a lateral thrust gait. The knee should then be examined with the patient sitting with their legs over the edge of the examining table. The position of the patella should be anterior, and you should look at both knees, see the related position between it and what you presume is the normal knee. The patella tracking can then be followed by asking the patient to flex and extend the knee with the examiner palpating the patella. There should be little lateral movement. Crepitus may also be noted as a grinding sensation between the patella and the femoral trochlear groove. Look at the patella. Look as he's flexing or extending. It should be within the patella groove. It should undergo a proper patella tracking, and this is controlled by all the muscles and all the fascia surrounding the patella, maintaining it in the central position. The knee should then be examined with the patient supine for all aspects of the examination. The contralateral knee can be used as a normal control. Effusion of fluid within the knee can be assessed by placing both hands on the knee, with one below the patella and one above the patella. You can see it. You ballot the patella. You force the fluid, if present, to move up from the tibia, and that present in the region of the femur move down. And then you apply a down pressure on the patella. If it taps then it tells you that there is fluid within the knee. Any fluid in the knee can then be displaced and palpated proximally and distally. The knee can be palpated to determine the specific site of maximum tenderness. The range of motion of the knee is measured with the knee in straight extension as 0 degrees of flexion, and a normal full flexion is approximately 135 degrees. Don't forget this range of motion. The collateral ligaments are then assessed by stabilizing the knee with one hand and placing a varus or valgus stress on the knee with the other hand. A normal knee will have a small amount of medial and lateral laxity in the collateral ligaments. Here, let me tell you, in this position, a full to test for the cruciate ligaments, you should relax these ligaments by flexing the knee around 15 to 30 degrees and then applying stress. It will tell you about this. There is any laxity or not. However, any laxity and medial side. The tibia is then held with thumb at the lateral joint line. The examiner then attempts to displace the tibia forward in relation to the femur. Translation, less than 5 millimeters should be noted, and the anterior cruciate ligament should be felt to snap taut in the normal knee. This shows you the Lachman test. The right hand holds the femur down. The left hand with the thumb holds the leg and then works on it to pull it upward with the femur. Will tell you whether it is anterior or posterior instability, indicating that the cruciate, anterior cruciate ligament is torn or not. Injury to the posterior cruciate ligament can be demonstrated by noting the degree of recurvatum, a back knee, hyperextension of the knee, which can be obtained passively compared to the contralateral knee. What about the quadriceps active test? Look at this test. You see he's flexed 45 degrees of the femur and around 90 degrees of the knee. Now, we know that the posterior cruciate ligament holds the tibia in relation to the femur. If it's cut, what happens? The whole tibia moves backward because there's no support from the posterior cruciate ligament. Now, if you ask the patient to contract the quadriceps, the tendon, the infrapatellar tendon, together with the patella, will pull the whole tibia to the front or anteriorly. And this is known as the quadriceps active test. This is the anterior drawer test used for the anterior cruciate ligament. This is the quadriceps sac backing, or the whole tibia is sagging behind because the posterior cruciate is gone. You compare it to the opposite leg. You see that there is a hollow defect in the left leg, while on the right it's straight. This shows you further for the posterior cruciate ligament. If you hold the toes up like is shown in the upper right slide, you see the whole tibia would sag down. Now, there is another test which will tell you about the posterior lateral corner where it's torn, and you want to tell this, let the patient lie supine and flex the knees, and you see that the side of the involved injury would externally rotate far more than the normal side. Also, with both knees flex 60 to 90 degrees, and the patient supine, the tibia on the deficient side will be noted to sag posteriorly compared to the uninjured leg, what I mentioned to you when viewed from the side, as is shown in the slide before, showing you the observed way, observing the position of the leg with respect to the femur in the patient who has an injury of the ligaments. Comparison to the contralateral knee is very important for examination of the collateral and cruciate ligaments. Okay, am I clear so far? This is the posterior drawer test, which tells us more about the posterior cruciate ligaments. The posterior cruciate ligaments can be demonstrated by the posterior drawer test and by the back test. The anterior cruciate ligament is demonstrated by the anterior drawer test and by the Lachman test. This shows you further the posterior drawer test, shows you the external rotation or a curvatum test, and it tells you about the dial test. The menisci are examined by palpation of their outer margin along the joint line at the proximal tibial articular surface. In addition, meniscal tears can be detected by a McMurray maneuver. This is done by flexing the knee internally and externally, rotating the tibia, and then extending the knee with a valgus force applied. This shows you the examiner putting his left hand on the knee and palpating the knee joint. And he holds the foot by the opposite hand at 90 degrees and starts rotating it laterally and inward and medially. And as he's doing it, he extends the knee. He tries to obtain a locking position within the knee. The patient will have a clunk or click, and they could possibly have pain. You have a positive McMurray test is when you get some locking or clunking or palpation of pain of the meniscus as the patient is flexing or extending. The same thing can be done on the opposite side, but rotation should be in the opposite direction. If a reproducible snap is palpated or pain elicited at the joint line, this is suggestive of a meniscal tear. Patients with meniscal tears will also report pain when asked to squat down with the knees flexed. Imaging. All of the available imaging techniques have been utilized in the evaluation of patients with knee problems. Plain radiographs are the most commonly obtained studies. Standing AP radiograph of both knees in a 70-year-old female with osteoarthritis of both knees with a valgus knock knee deformity of both knees. One should know the asymmetric space between the medial and lateral femoral condyles and tibial surface. You see that there are osteophytes. You see that there are sclerosis. You can classify them according to Kalgren technique, Lawrence list. But you have to know that you can have from stages 1 to 4 sclerosis and cystic formation and increased deformity of the knee with symptomatology. Plain radiographs are helpful in evaluation of fractures and subluxation of the joint. Also, the condition of the articular surfaces can be investigated. The standard series of routine X-rays of the knee should include a standing anterior-posterior radiograph of both knees, a lateral view, and immersion or sunrise view. This is immersion view or sunrise. The patient lies supine. The knee is flexed. You put the cassette in front of the mid aspect of the tibia, and you apply the tube at an angle of 30 degrees with the horizontal, and you shoot the X-ray. This is immersion view or sunrise view or whatever you want to call it. And you see where the tube is put, you see where the cassette is applied, and it gives you an idea of the patella, where is it. So the more prominent condyle is shown in blue arrow, and it denotes the side being if it is prominent on the left. It is the left femur. A normal patella has a degree of tilt to it. Lower right image. The right image demonstrates patella subluxation. And let me see, I have to get this a bit out. And as it is rotated lateral to the rotrocular groove. So you have to keep this in mind. Okay. Look at this. You see the immersion view of how well it's demonstrating the position of the patella. Look at it. Look at the larger facet, which is lateral of the patella. This is the important facet. This is what we decide on with subluxation or dislocation. Look at the patella groove. This fossa is very important. It is one of the causes of patella subluxation if it's flat. Keep this in mind. The sunrise view is a view taken with the knee in 45 degrees of flexion with the beam directed inferiorly and the patella to the patellar articular surface. I want to show it to you. This is how we take the sunrise view at 15 degrees. So know about immersion view, know about the sunrise view. These are views in examinations. There should be a space of 5 to 10 millimeters between the ends of the femoral condyles and the tibial surface and beneath the patellar surface and the femoral trochlear. This clear space is in fact occupied by articular cartilage. Routine radiography is an excellent tool for the evaluation of the knee for trauma, arthritis, and alignment. Plain radiographs however, only demonstrate the osseous structures. As mentioned earlier, the soft tissues provide stability and allow the knee to function. Arthrography has been used in the past to evaluate the knee for meniscal pathology. However, the technique was inaccurate and invasive. The development of arthroscopy allows the direct visualization of the structures within the knee in a minor surgical procedure. You can see them directly. However, this technique is also invasive, and while arthroscopy is accurate, the procedure is relatively expensive compared to an imaging modality alone. Nuclear medicine studies are of limited use in the knee. These studies are sensitive. However, the specificity of these studies is limited. Magnetic resonance imaging has provided a dramatic step forward in the ability to diagnose soft tissue injury to the knee. MRI provides accurate and non-invasive evaluation of all of the soft tissue structures within the knee. This is a slide which demonstrates a normal T1 weighted magnetic imaging sagittal image of the medial meniscus. In B, you have a schematic illustration showing the section cut. If you look at the slide below on the left, you see the straight line tells you where the cut is. We know that it's wedged right and left. I mean, you have wedging. When the view passes through it, you see that you can see the meniscus, you can see it in a wedged form, and if you have any fissure, it will be apparent on. You can also see the cruciate ligaments, which are well demonstrated here. So don't forget the medial collateral ligaments. You can see the superficial and deep ligaments. MRI is currently the study of choice for the evaluation of intra-articular pathology within the knee. Knee pathology. Just want to think water. All right. Knee pathology. Soft tissue injury common in the knee. A knee with a bloody infusion after an injury has an incidence as high as 80% of significant soft tissue injury. If it's associated with a bony fracture, you see that you can look at the effusion and you will see that there are fat globules within the hematoma. The differential diagnosis of a post-traumatic bloody infusion in the absence of an intra-articular fracture is a meniscal tear, an anterior cruciate ligament tear, and a patellar dislocation. I love to ask these questions. Give me 3 possible causes of an athlete who comes to you that following a fall or whatever action he's doing, he sustained the swelling of the knee which was quite painful. And what could it be? From the history alone, you have to say, my God, this patient has either a meniscal tear, an anterior cruciate ligament tear, or a patella dislocation. Meniscal tears. Tears of the meniscus can occur in two settings. One is the result of a specific injury. This usually involves a twisting injury with the knee in some flexion. Swelling and pain are noted immediately after the injury. There is increased pain with attempts at movement, and there is limitation in the range of motion. Pain with squatting, ما بيعرفش, down or rising from a chair is commonly reported. The torn meniscus can block the motion. Occasionally, the knee can be gently manipulated to reduce the torn meniscus fragment, and motion will be restored. However, the fragment will frequently redisplace, and intermittent locking may occur. This form of tear is usually in younger patients with tight meniscal tissue. In older individuals, the meniscal tissue soften and the edge becomes frayed. As this occurs, the frayed edges can become entrapped between the edges of the bone, initiating a tear which can extend into the meniscal substance. This tear can occur with little or no trauma, with minimal swelling and pain initially. The diagnosis is made by joint line pain, effusion, and rarely locking. Patients with locking will frequently require arthroscopic surgery to debride the torn portion of the meniscus. In older patients with meniscal tears, if the tear does not cause locking, it frequently can be treated with non-steroidal anti-inflammatory drugs, medications, and an intra-articular corticosteroid injection. These treatments will reduce the effusion and pain. With continued activity, the soft meniscal tissue can be worn down and a stable edge re-established. Ligament injuries. Injury to the ligamentous structures manifest by instability of the knee. In addition to pain and swelling, patients will report a sense of knee shifting or giving way. This may be with only specific activities, such as descending stairs or when turning on the loaded extremity. The initial management of these injuries is best to have rest, ice, and elevation of the extremity. Rest, ice, and elevation of the extremity. A splint or knee immobilizer can also be helpful to protect the knee. As the initial pain subsides, it is important to begin to work on restoring the range of motion using a brace to protect the injured ligament. As the pain further decreases, strengthening is begun. If the knee remains unstable after the strengthening program is completed, the patient may be a candidate for surgical reconstruction. Patellofemoral pathology. Patellofemoral joint is one of the most common areas of pain in the knee. Common complaints are anterior knee pain, which is aggravated by activities involving high loads on a flexed knee, such as stair climbing or bicycling. This pain can be the result of degenerative changes in the patellofemoral articulation or a result of maltracking of the patella within the trochlear groove. A grinding or snapping sensation may also be noted. Pain is usually relieved by rest. However, if the patient is sitting for a prolonged period of time with the knee flexed, such as in a theater, on a plane, or during a long car ride, anterior knee pain will result. Frequently, patients will try to change the position of the knee to relieve the discomfort. This symptom is referred to as the movie sign. The movie sign is when the patient tries to compensate for the pain by changing positions of the knee, extension, flexion, or any position that could relieve him of the pain. And it is indicative of degenerative changes of the patellofemoral joint. Softening of the articular surface is referred to as chondromalacia patella. This can be a primary problem, or it may be secondary to excessive trauma to the joint due to maltracking of the patella within the trochlear groove. This, in brief, shows you the cartilage of the patella becoming irregular, soft, and this is known as chondromalacia patella. The treatment of these conditions is primarily non-operative. Improving the patella tracking can be done through a series of exercises to retrain the quadriceps and through patella mobilization exercises. Exercise program needs to be maintained for a minimum of 6 to 8 weeks to demonstrate benefit. The symptoms can frequently be recurrent. If the symptoms are recurrent and do not respond to the non-operative regimen, and the patella maltracking is evident, operative intervention may be indicated. Operative intervention is directed at correcting the patella tracking and to maximize the quadriceps function with post-operative physical therapy. Now we come to a section which is a bit out of the topic of sports, but sports leads to it, so I could not leave this outside. I would call this section a situation before arthroplasty. The management of arthritic symptoms within the knee is similar to the management of arthritis elsewhere. The non-operative management of arthritis within the knee consists of a 5-modality approach. The first line of therapy is the use of non-steroidal anti-inflammatory drugs. These medications will reduce the pain and swelling associated with the knee. Although all of the non-steroidal anti-inflammatory drugs function in a similar fashion, there is a wide variation in the individual's or patient's response. Therefore, minimally 2 or 3 different non-steroidal anti-inflammatory drugs should be tried. The most common side effect of this course of treatment is, of course, as everybody knows, gastritis and gastrointestinal intolerance. The injection can quiet their pain and restore them to a baseline level of discomfort. The injection should not be utilized for the control of baseline pain. If the injection is required at a frequency of greater than once every 6 to 8 weeks, what I'm speaking about is steroid. You can use methylprednisolone or any other form of steroids. You can inject the knee, which is arthritic, but you should make it a point not to inject them frequently. Make it a point to inject 2 or 3 injections per year, no more than that. Of course, physical therapy can be very helpful in the treatment of arthritis of the knee, as the soft tissue sleeve is very important to the function of the knee. Optimizing functions of the soft tissues can reduce the symptoms of arthritis. The physical therapy should be directed at maintaining the range of motion of the knee and optimizing the strength of the quadriceps and the hamstring muscles. In the late stages of degenerative arthritis, the physical therapy may worsen the patient's symptoms and should be limited to a program within the patient's tolerance. Assistive devices such as cane crutch may aid in the management of the arthritis of the knee. This can limit the stress across the painful knee and improve the patient's walking tolerance. The final approach to management of arthritis of the knee is modification of activities. This includes alterations of the patient's activities, such as sports, work environment, and possibly even assisting in arranging special parking for the patient. Frequently, patients with significant knee arthritis are also overweight. They have to lose weight. Weight loss in these patients can significantly reduce symptoms and the need for other treatment modalities. As the force across the knee joint may be 3 to 5 times the patient's body weight, weight loss can have a significant impact on the patient's knee symptoms. Meniscal injuries, the type of meniscus injury. The medial and lateral menisci have important roles in the knee joint. Their unique anatomy or anatomic structure provides both static and dynamic stability to the knee. We spoke about this, and the histologic and biologic composition of the menisci allows load distribution proprioception, lubrication of the whole joint, biomechanical and clinical results have confirmed the importance of radial, horizontal, and root tears of the meniscus. The menisci are wedge-shaped. They are fibrocartilaginous structures situated between the femoral condyles and the tibial plateau. These structures have many functions in the knee, including proprioceptive feedback, load distribution, joint physiology, loading, joint lubrication, and maintenance of tibiofemoral stability and congruity. We spoke about all these. Now we're going to go into detail. The substance of the menisci is a solid extracellular matrix and water. Fibrochondrocytes are the predominant meniscal cell, and they produce the extracellular matrix. We know that type 1 collagen comprises most of the extracellular matrix. Small amounts are present of 2, 3, 5, and 6 collagen also are present. 4 is absent. Other components besides the type 1 collagen, besides the type 3, 5, 6 collagen, are proteoglycans, such as aggregants. Proteoglycans consist of a protein core covalently bound to negatively charged glycosome, aminoglycan polysaccharides. Proteoglycans attract and bond water, which comprises 65 to 75% of meniscus volume. Type 1 collagen is most abundant on the superficial zones of the meniscus to provide tensile strength. This is the purpose of type 1 collagen. Proteoglycans and water are found in the deeper zones of the meniscus, and these provide compressive strength. This is what we mean when we're speaking about shock absorption. Shock, the water, the compression force is coming on the water and on the proteoglycans. And these are in the deeper layers of the meniscus. The collagen fibers in the deeper layers are randomly oriented together with the superficial aspects, so that if a force comes, they will tighten in different directions. In the deeper zones, the collagen fibers are oriented circumferential more often than what is present in the superficial zones. And they are stabilized by intermittent radially oriented fibers that anchor the circumferential fibers. So let us say, if you look at the superficial zone, you see that they are randomly oriented. You can have fibers longitudinally in the vertical direction, in the horizontal direction, etc. Depends on the force. And we said that the type 1 collagen are involved in tension, while the deeper fibers, which are type 2, 3, 5, and 6, are oriented so as to prevent any compressive force on it. Don't forget, superficial, type 1. Deep are the following types. They are joined by proteoglycans, namely aggregants. and this gives the force to the meniscus. You can see each of them over here. You see the type 1, which are collagen fiber network at the surface. You can see deeper down. All these fibers are oriented to create a tension, compensation, and a compression force on the meniscus to protect the femoral condylar cartilage and the tibial condyles. So here we have a schematic drawing showing the collagen fibers of the meniscus. The superficial collagen fibers are randomly oriented to resist shear stress, to resist tension. The deeper fibers are oriented circumferentially to dissipate loads as hoop stresses, as compression forces come. The circumferential fibers are secured by radially oriented tie fibers. So all these are connected together. This orientation provides a tensile strength superficially, as well as absorption and dissipation of hoop stresses from axial loading during weight bearing, not weight bearing, sorry, by 50% in knee extension, as much as 85% in flexion. In these ways, the menisci protect the articular cartilage from excessive loads and contribute to joint congruity during weight bearing. All in brief is to tell you that they are true shock absorbers. The medial and lateral menisci have different gross anatomic features. Each has an anterior horn, a body, and a posterior horn. The medial meniscus is semicircular or C-shaped. It covers a portion of the medial tibial plateau. You see the slide, it's quite descriptive of the anatomy. It is an illustration taken from one of the textbooks, which shows the menisci and the proximal tibial plateau. The medial meniscus is C-shaped. The insertion of the posteromedial menisci root is pointed out by the arrows, is shown just anterior to the posterior cruciate ligament. The insertion of the anteromedial root or meniscus root is shown on the anterior tibial plateau, extending down the anterior proximal tibia. The lateral meniscus is more circular in shape than the medial meniscus, and the anterolateral meniscal root inserts just lateral to the anterior cruciate ligament, the ACL, on the tibial plateau. The posterior lateral meniscal root is shown with its anterior menisco-femoral ligament, which is called the ligament of Humphrey. And behind the posterior cruciate ligament, you have the ligament of Ristberg. All these support the meniscus. We know that the lateral meniscus is more mobile than the medial. We know that the lateral meniscus is not so much attached to the surrounding soft tissues as the medial. We know that the medial meniscus is attached to the capsule by coronary ligaments and firmly attached to the deep layer of the medial collateral ligaments. So you have to keep this in mind. You have to know the difference between both menisci. The medial menisci is smaller than the lateral, but it is bulkier. It is thicker than the lateral meniscus. The posterior horn is approximately 11 millimeters wide, and the anterior horn is slightly smaller. Pay attention. The posterior horn of the medial meniscus is 11 millimeters wide. Anteriorly, it is thinner. The medial meniscus is attached to the deep medial collateral ligament through the coronary ligaments and the joint capsule, and its mobility, therefore, is limited. The inferior aspect of the posterior horn is attached to the tibia by meniscotibial ligaments or coronary ligaments. The lateral meniscus is more circular in shape than the medial meniscus, and it has an equal size of the anterior and posterior horn, while in the medial, the posterior is 11 millimeters, while the anterior horn is smaller. At the posterior lateral meniscus attachment of the popliteal meniscus fascicles extend from the meniscus to the posterior capsule, and it creates a popliteal hiatus as the popliteus tendon becomes intra-articular. The meniscofemoral ligaments connect the posterior horn of the lateral meniscus and the medial femoral condyle. The anterior meniscofemoral ligament, as I mentioned, is that of Humphrey. It courses anterior to the posterior cruciate ligament, and the posterior meniscofemoral ligament is Risberg and courses posterior to the posterior cruciate ligament. We love these two ligaments. We ask questions about them. We ask about the functions, about the ability, what's the purpose in the board exam. This is a slide showing you the posterior meniscofemoral ligament, which is the transverse Risberg ligament, while the front is the Humphrey ligament, and these give further stability of the meniscus. They attach to the posterior horn. Look at the meniscus. Look at the superficial fibers of the meniscus, which are type 1 collagen. Look at it. The ligaments are haphazard, and the whole point is to prevent tethering of the meniscus. Deeper down, it's circumferential, and these tolerate loads. You should notice the anterior to posterior cruciate ligaments, and you should notice that both menisci are joined anteriorly by the transverse ligament. Because the lateral meniscus has less continuous attachment to the capsule than the medial meniscus, it has more mobility, which may confer a protective effect. The most common connection between the medial and lateral meniscus is the transverse intermeniscal ligament, which is present in 60 to 94% of knees. You'll see it, it's over here. I marked it in red. Over here it's present. This ligament is the only connection from the front that we have between both menisci. Keep this in mind. A posterior and medial or lateral oblique intermeniscal ligament also can be present. Speaking about the vascular supply of the menisci. The vascular supply of the menisci comes from the superior, middle, and inferior geniculate arteries. We all should know about the zones of circulation of the meniscus. We should know that the outer third is well supplied by blood vessels, and it's called the red zone. You should know that the middle third is combination of red and white zones. And you should know that the mesial third is the white zone, where it obtains its nutrition from the synovial fluid. So keep this in mind. This slide I like very much because it tells you about the blood supply of the meniscus. Shows you the outer third, the middle, which is a red-white zone. Then you have the completely rarefied zone, no blood. It's called the white zone, and obtains its nutrition from the blood, from the synovial fluid. So the image shows a cross-section of the medial meniscus. The vascular supply penetrates the outer 10 to 30% of the meniscus. This is called the red zone, as I told you. The middle third of the meniscus is the transition zone between the vascular and avascular regions. This is known as the red-white zone. The inner third of the meniscus is the avascular zone, which is known as the white zone. So pay attention to this. The anterior and posterior root attachments are well vascularized by synovial branches. Zones of the menisci are described based on its vascular anatomy. The outer third, the well vascularized region, as we said, is the red zone, and then the red-white zone, and finally the white zone. The location of a meniscal tear through the zones partly determines the treatment because the potential for healing increases with vascularity. Sorry, I want to drink. The portion of the menisci that is not well vascularized receives nutrition through diffusion from the synovial fluid during loading. You know, loading, as you apply compression and relief of load, pumps the synovial fluid into the region. Neural elements are found mostly in the periphery of the anterior and posterior horns. The menisci are believed to have a role in proprioception because of this configuration. The role of the menisci in load sharing. During weight bearing, the menisci effect and the diffuse load between the femur and tibia through the development of deep stresses that rely on intact circumferential collagen fibers. Biomechanical studies found that a partial meniscectomy necessitated by the presence of a bucket handle or peripheral longitudinal tear increases peak tibiofemoral contact pressure by 65 to 110%. Imagine how much load it increases the contact pressure, and that the total meniscectomy increases the pressure by as much as 235%, 235%. So you have to keep this in mind. In the past, we used to do many meniscectomies. What was the result? We observed at the later date, that 10 years, 15 years, the result was degenerative arthritis. So pay attention, please pay attention. In a cadaver study, an incremental increase in peak contact stress and a decrease in contact area were found as the size of the radial tears increased and as a larger amount of meniscal tissue was removed. So we need the menisci. We need them to protect the knee joint. A radial tear, 51% or 75% of the width of the medial meniscus, and a partial or total meniscectomy caused a substantial change from the intact state. Only a radial tear more than 90% of the width of the medial meniscus or a partial meniscectomy of such a radial tear substantially increased peak contact pressure and caused the peak contact to shift to a more posterior location. Lateral radial meniscal tear of the width of the lateral meniscus and a partial meniscectomy were found to significantly increase the contact pressures. These biomechanical data explain the clinical observation of meniscal extrusion and progressive degenerative osteoarthritis in knees with a radial or complex meniscal tear. Okay, so you have to think of this, that this is very, very, very important. You should pay attention. The medial and lateral menisci as stabilizers. Don't forget this. Biomechanical studies have contributed to the insight into the function of the menisci as dynamic stabilizers. We said that the muscles are dynamic. We said that the meniscus are dynamic. We spoke about static stabilizers, which are the ligaments under specific conditions and the shape of the bone. Sectioning of the medial meniscus led to increased tibial translation and a strain on the ACL during anterior tibial translation. That occurs with the ligament test. I would like to tell you that when the ACL is torn, what stabilizes the tibia with respect to the femur? The next stabilization that comes after it, if it's torn, is the posterior horn of the medial meniscus. And it is for this reason, with time, if the ACL is not treated and the patient is active sporty-ish, then the posterior horns of the medial meniscus is likely to be torn. So you have to keep this in mind. Another sectioning study found that in the absence of an intact ACL, the medial meniscus acts as a secondary stabilizer during anterior tibial translation. The lateral meniscus was found to be an important stabilizer for rotatory and valgus loads during the pivot shift maneuver in ACL deficient knees. So one is rotatory stabilizer, and the other one is an anterior posterior stabilizer. Keep this in mind. If you're spoken about the lateral meniscus, how does it stabilize? Through rotation and valgus loads. Keep this in mind. The anterior translational stability conferred by the ACL protects the posterior horn of the medial meniscus. يعني هول معتمدين على بعض. The ACL and the posterior horn of the medial meniscus. If one goes, one takes over the major load, but with time, it degenerates. These results emphasize the important static and dynamic role of the menisci in knee kinematics. Diagnosis. A thorough patient history is important for both the diagnosis of meniscal tear and treatment decision making. the patient's demographic profile. Just 1 second. Sorry, I was putting the air conditioner on. The patient's demographic profile, pre-injury level of activity, earlier symptoms or injuries, and mechanism of injury can guide the examiner toward an accurate diagnosis and an appropriate treatment plan. You have to be organized. You have to organize your thoughts and what you found by physical examination, by what you found by history. Put them all together, and then you arrive at the treatment plan. Don't forget about these exams. I put it repeatedly because I would ask many of these questions in the exam. I'm sure others would ask them in the exam. You should know how to do a proper Lachman test. You have to do a pivot shift test. You have to know what does it tell you about. You have to demonstrate it to us many times. So this is very important. Do the anterior drawer test. Sit on the foot, the leg forward or behind. Do a McMurray test. How would you do? Where would you put your thumb of the other hand on the joint? For what purpose? You have to do the applique compression test, which would tell you the difference between a ligament tear and the meniscus. By applying pressure and rotating the leg with pressure load on the femur, you will be demonstrating a meniscus tear if the patient has pain. If you distract the foot as you're distracting it, rotate it laterally or outward or medially. And if the patient has pain, think of the ligament. So all these tests are important. You have to know how to do a dial test. This would tell you about posterolateral corner injuries. Letting the patient lie on his tummy. You'll see that the extremity will go into external rotation on the involved side as you compare it to the normal side. Patients with a traumatic tear may have pain onset during a twisting mechanism or deep flexion. Occasionally, a popping sensation is reported when you're doing a pivot shift test. Approximately 1/2 to 2/3 of patients have knee swelling, so you have to pay attention to this. Mechanical symptoms such as catching or frank locking were observed in 12% to 69% of patients in 2 recent studies. These are important symptoms because they suggest an unstable tear. The physical examination should begin with assessment of overall lower limb alignment and inspection for external signs of trauma or the presence of an effusion. Active and passive range of motion is recorded with a rotation of any mechanical block to motion. The status of the collateral and cruciate ligaments is important to test because the presence of an injury affects treatment decision-making. Palpation of the joint line may elicit tenderness in the region of a tear. Posterior horn tears are most prevalent, and therefore the posterior joint line is common location for tenderness. The meniscus-specific McMurray, aptly, the Thessaly test is done exactly by rotation with the knee flexed around 45 degrees and the patient is standing, and he's asked to rotate right and left, and they will have pain in the region where the tear is present. They will have pain. The McMurray test involves taking the knee through a range of motion while internally and externally rotating the tibia relative to the femur and applying an axial load. For the Apley test, the patient is prone with the knee flexed to 90 degrees. The examiner applies an axial load while the tibia is rotated internally and externally. This will tell you whether the meniscus is torn or not. For the tesserae test, the patient stands on the affected leg and performs a one-legged squat of approximately 20 degrees. I think it should be a bit more than 20 degrees to demonstrate any tear or anything going wrong. During flexion and extension, the patient also rotates the torso to create intense and external rotation of the tibiofemoral joint. Each of these functional tests is designed to trap the pathologic meniscus under axial load and rotation and pain, and for mechanical symptoms should be recreated. In a patient with an isolated meniscal tear, joint line tenderness was found to be an accurate test in 81% of patients, compared with 55 to 77% for McMurray test and 61 to 80% for the tesserae test. This shows you the tesserae test. Patient stands, 20 degrees of flexion. I think a bit more would be better. And you ask the patient to rotate inward and outward and see whether he has pain. Where is the pain localized? Ask him to point it as he's doing so. And this would tell you whether there is a meniscal injury or not. With associated ligamentous or condylar injury, the physical examination can be particularly challenging because the tests lose their accuracy for meniscal pathology. However, the combination of joint line tenderness and a positive McMurray or tesserae test has sensitivity and specificity approaching those of an isolated meniscal tear. Radiographic evaluation of a patient with knee pain should begin with weight-bearing radiographs, including AP in extension and lateral views. A PA in 45 degrees of flexion views. This is known as the Schultz view or the Ron-Huffenberg view. Why do we take this test? We take this test because we know that degenerative arthritis of the knee usually begins posteriorly in the mid aspect of the condyles, not anteriorly. So we take them in 45 degrees flexion to bring this portion of the condyles forward so that we can view them on X-ray. A Merchant view of the patellofemoral joint is essential. Signs of osteoarthritis or trauma can provide clues to the internal environment of the knee and the status of the meniscus before the onset of acute pain. Osteoarthritis can signify a degenerative meniscal tear, and trauma can be associated with an acute tear. MRI is useful for confirming a clinical suspicion of a meniscal tear. Meniscal tears can be well evaluated with proton density weighted MRI. A tear can be described as longitudinal, vertical, horizontal, radial, flap, parrot beak, bucket handle, degenerative, or complex tears. The criteria for MRI diagnosis of a meniscal tear include increased signal intensity extending to the articular surface, low signal meniscal substance, distortion of the shape or size of the meniscus, which signifies missing meniscal tissue, or a displaced meniscal fragment. This is a proton density weighted magnetic resonance imaging, which shows meniscal tears. A sagittal view shows a complex meniscal tear. The signal extends to the articular surface. In B is the coronal view, which shows a horizontal cleavage tear of the medial meniscus at the junction of the body and posterior horn. And in C is a sagittal view, which shows the double posterior cruciate ligament sign, and this would tell you that there is a bucket handle tear, and one should not confuse this. You see a double ligament appearance. The sensitivity and specificity of 1.5 and 3.0 Tesla MRI diagnosis of medial meniscus tears, as confirmed with arthroscopy, were found to be 93 to 96% and 88 to 90% respectively. MRI was less sensitive to 77 to 81, but more specific, 98 to 99% for lateral meniscus tears. In general, 1.5 Tesla MRI was slightly less sensitive and specific than 3.0 Tesla MRI, but the difference did not reach significance. A report of 3.0 Tesla MRI for detecting posterior meniscal root tears found sensitivity of 77% and specificity of 73%. These findings may be attributable to the radial orientation of many posterior root tears, which makes them more difficult to see on MRI. The patient history and physical examination remains the most important diagnostic tools. To be considered a pertinent finding, a meniscal tear seen on MRI should correspond to the patient's history and positive clinical examination findings. Treatment. The treatment options following diagnosis of a symptomatic meniscal tear include observation, excision, partial meniscectomy, repair, and replacement. The treatment should be tailored to the patient and the type of tear. Observation can be chosen for stable peripheral tears, smaller than 5 to 10 millimeters. Some degenerative tears that do not cause mechanical symptoms, and tears in the setting at substantial osteoarthritis. Unstable tears causing mechanical symptoms, tears in the avascular zone, such as radial or flap tears, and degenerative tears without substantial osteoarthritis can be treated with partial meniscectomy. During partial meniscectomy, the unstable portion of the meniscus is identified and excised, and the adjacent tissue is shaped into a smooth and stable contour leading into the excised segment. The surgeon should preserve as much meniscal tissue as possible and avoid creating a defect traversing the entire width of the meniscus. Clinical studies with long-term follow-up of partial meniscectomy for the treatment of meniscal tears found an increase in osteoarthritic changes within the affected compartment. Partial meniscectomy for the treatment of radial tears that were within 1 centimeter of the posterior horn led to progression of osteoarthritis in 35% of patients at a mean 77 months follow-up. At 5 to 7 year follow-up of 46 patients, 1/3 had progression of Kellgren-Lawrence grade 1 to 2 osteoarthritis to grade 3 or 4 osteoarthritis. Although the modified Lisholm knee questionnaire score often significantly improved after partial meniscectomy, only 56% of patients reported pain improvement. In a systematic review of treatment for traumatic meniscal tears, both the short and long-term reoperation rates were higher after meniscal repair than after meniscectomy, 16.5% versus 1.4% and 20.7% versus 3.9% respectively. However, there were on plain radiographic degenerative changes in 78% of knees after meniscal repair, compared with 64% of knees after meniscectomy. These results were evaluated by another study that compared partial meniscectomy and inside-out repair of at longitudinal tears. Almost 80% of patients with arthroscopic meniscal repair had an osteoarthritis progression, compared with only 40% of patients with meniscectomy at 8 to 10 year follow-up. More than 96% of patients who underwent arthroscopic meniscal repair returned to their pre-injury level of sports activity, compared with only half of these who underwent a partial meniscectomy. Similarly, at 4-year follow-up, patients who underwent repair of a medial meniscal root tear had less progression of osteoarthritis and better clinical scores than those who underwent partial or medial meniscectomy. Preservation of the integrity of the articular cartilage or quantitative MRI has been associated with healed meniscal repair. This finding supports the reported clinical results, with increasing evidence that both meniscal injury and partial meniscectomy are linked to the development of osteoarthritis. There has been a shift toward meniscal repair as the treatment of choice for meniscal tears. The goal of meniscal repair is to provide the meniscus with structural support and the ability to heal, and therefore to preserve its integrity and function. In general, traumatic longitudinal tears occurring in the red zone in patients younger than 30 years of age are believed to be most amenable to a successful repair, although good results also were found in the red-white zone repairs in younger patients. So, this is an arthroscopic view showing a longitudinal tear in the vascular red zone of the medial meniscus. This is an A, and the repair of the tear with vertical mattress sutures shown in B. Because of their blood supply, tears in the red zone are most likely to heal, followed by tears in the red-white zone, while white zone tears are avascular and thus have limited potential for healing. The failure and reoperation rate was found to be higher for medial and lateral meniscal repairs as short and medium-term follow-up. Concomitant ACL reconstruction positively correlated with healing, and age younger than 30 years trended towards a positive correlation with healing. Tears larger than 2 centimeters and tobacco smoking negatively affect healing rates. Open repair has largely been replaced by arthroscopic repair unless an arthrotomy is needed for another injury such as a tibial plateau fracture. Arthroscopic repair can be done using an outside in, inside out, or all inside technique. Outside in repair often is chosen for an anterior horn or meniscal body tear, which is difficult to reach using an inside out or all inside technique. Spinal needles are placed from outside the joint through the meniscal tear, and suture is shuttled through the needles under arthroscopic observation. A small skin incision is made and a knot is tied directly on the outside of the capsule with care to avoid entrapping any superficial soft tissue. An inside-out repair commonly is used for a posterior horn or posterior meniscus body tear. Long flexible needles are placed with the use of specialized guides through the meniscal tear and are retrieved outside the joint. Suture is shuttled through the tear and tied over the capsule through the open posterior incision. Accessory incisions are necessary for needle retrieval and not tying. Retractors are used in the accessory incisions to protect the popliteal neurovascular structures as well as the saphenous nerve and vein medially or the peroneal nerve laterally. MRI at an average 43 months follow-up after inside-out meniscal repair with vertical mattress sutures showed a 100% healing rate for partial tears and 83% rate for full thickness tears. All inside meniscal repair has the advantage of being less invasive than inside out or outside in techniques with no required accessory portal and therefore less risk of superficial vessel or nerve injury. Multiple devices are on the market, each of which is inserted through a standard anterior portal using a guide. The trajectories possible through the anterior portal makes the all-inside devices most suitable for tears in the posterior horn or mid-body of the meniscus. Despite the small risk of injury to the popliteal fossa structures if the device penetrates the posterior capsule tone deeply. A recent review of patients treated with second-generation all-inside devices reported no neurovascular complications. The second-generation insertion devices currently on the market mimic inside-out sutures configurations to make the device more user-friendly and safe for the articular cartilage. The improved suture fixation mechanism reduces the risk of device migrating or unsending. Midterm outcomes are promising at an average of 7-year follow-up. Of 33 all-inside meniscal repairs, 34% were healed, accounting for clinical criteria. Biomechanical studies comparing the strengths of inside-out and outside-in all suture repairs had conflicting findings. A systematic review of 41 studies on the load to failure of suture repairs compared with repairs using all inside devices found a higher load to failure with suture repairs. A vertical mattress suture configuration was found to have a greater load to failure than a horizontal mattress configuration. In others studied simulated inside-out vertical mattress suture fixation and compared it with fixation using several available all-inside devices. Inside-out repair had a failure load of 73 to 88 newtons and a mean displacement of 2.85 to 2.75 millimeters after 100 cycles, and all except one all-inside device had comparable performance. Clinical results of all suture and all inside techniques were generally equivalent in several recent systematic reviews and meta-analysis. A systematic review of heterogeneous meniscal repairs with or without concomitant ACL reconstruction found that 61.7% of repairs completely healed. Inside-out repairs of ACL intact and ACL reconstructed knees had a 77.7% success rate, and all inside repairs had a 75.7% success rate. A systematic review of inside-out and all inside repairs of isolated bucket handle meniscal tears without concomitant ACL reconstruction found clinical healing rates of 33 and 31% for inside-out and all inside repairs, respectively. All inside repairs led to more local soft tissue irritation and implant migration, and inside-out repairs had a higher rate of nerve injury. The ability to return to sport after meniscal repair has been investigated. A study of elite athletes found that 31% were able to return to sport, an average of 5.6 months after surgery. In this active population, the failure rate was 26.7% at an average of 41 months. A study of high-level salsa players found that 39.6% were able to return to the same activity level in an average of 4.3 months after surgery. At 5-year follow-up, up 45% was still participating in SOSA. It can be difficult to interpret imaging after meniscectomy or meniscal repair. The diagnostic criteria for a retear after a meniscectomy in which less than 25% of the native meniscus was removed are the same as for a primary tear, and the diagnostic accuracy is similar. Tears requiring a more extensive meniscectomy or a meniscal repair may reach the vascular zone of the meniscus, and these tears heal with fibrovascular tissue that can mimic the hyperintense signal of a retear. Based on MRI appearance, tears are classified as fully healed if there is no fluid signal in the repair site, partially healed if fluid extends into less than 50% of the width of the repair site, and not healed if the fluid extends into more than 53% of the repair site width. Failure of meniscal repair can be attributed to, first, inadequate meniscus fixation strengths. 2, poor vascular supply at the repair site. 3, concomitant knee instability caused by ligamentous laxity. The medial and lateral menisci have a secondary role in stabilizing the knee and repairing a posterior horn meniscal tear in an ACL deficient knee without correcting the anterior laxity can lead to a retear or compromised healing. The reason for the failure should be considered in deciding whether a revision meniscal repair or a partial meniscectomy is preferred. Revision meniscal repair was evaluated in 15 patients who had undergone primary repair using different techniques. The revision repair failed in 5 patients at an average of 25 months after surgery. The presence of degenerative changes at all 5 revision repair sites suggested that avascularity or instability played a role in the degeneration of the meniscal tissue. In the patients who did not have a tear after the revision repair, the average Lisholm score improved to 97.4 of 100. Root tears. The role of the posterior meniscal root attachment and the underestimated prevalence of this injury have received attention recently. Both degenerative and traumatic tears can occur. A traumatic tear often is associated with multi-ligamentous knee injury or injury occurring during deep knee flexion. The medial posterior root is less mobile than the lateral root and therefore is more susceptible to isolated injury. In contrast, a lateral root tear is most common in association with ligamentous injury. Tears of the posterior medial meniscus root can increase contact pressure, promote external rotation, and they would have lateral tibial translation, which are corrected with repair of the posterior medial meniscal root. So you have two conditions. The ACL torn, the whole load comes on the posterior horn of the meniscus. If you have a posterior horn tear of the medial meniscus and you want to repair it, it can be corrected and translation will definitely improve. But it won't last for long. You should repair the ACL and the posterior horn tear. Repair of the medial and lateral root tears substantially decreases the contact pressures within the medial and lateral compartments. Biologic treatments. The mechanism of healing in the vascular portion of the meniscus involves an initial inflammatory response and fibrin clot formation, followed by migration of undifferentiated mesenchymal cells from the vasculature, which leads to new matrix formation and healing through fibrous scar tissue. Synovial cells also can participate in the repair response. This process has led to recommendation that refination of the peripheral meniscus and capsule and synovial abrasion should be done during meniscal repair to increase vascularity and resulting migration of vascular-derived undifferentiated cells to the repair site. There also is interest in the direct application of pluripotential stem cells into the joint for augmentation of healing in meniscal repair. In animal models, synovial mesenchymal stem cells injected intra-articularly during meniscal repair adhered well to sites of meniscal injury and differentiated into meniscal fibrochondrocytes, thus improving the amount of meniscal tissue formation 1 to 4 months later. A human study of intra-articular injection of bone marrow derived mesenchymal stem cells found that the meniscal volume substantially increased in 24% of patients within 1 week of meniscectomy. Patients also had osteoarthritis, had substantial improvement in pain. In a rabbit model, adipose-derived stem cells delivered to the site of a longitudinal meniscal tear were found to improve the healing rate and the amount of regenerated meniscus in both the vascular and avascular zones. The effect of adipose-derived stem cells was apparent after the acute repairs. Concomitant ACL reconstruction was found to be positively correlated with meniscus rates, probably because bone marrow-derived mesenchymal cells were released during tunnel reaming. Bone marrow stimulation achieved by drilling a 5 millimeter hole in the intercondylar notch recently was reported for augmentation of healing of avascular horizontal cleavage tears. The clinical healing rate was 91%, and 3% of patients had complete healing at second look arthroscopy. A relatively short duration of meniscal symptoms was associated with superior clinical outcome score. Platelet-rich plasma, PRP, is a source of anabolic growth factors such as insulin-like growth factor 1, vascular endothelial growth factor, fibroblast growth factor 2, transforming growth factor 13, and platelet-derived growth factor AB, all of which have been isolated from meniscal repair tissue. There is evidence that PRP application at the site of meniscal repair increases the adherence and content of fibroblasts and chondrocytes and improves the histologic appearance of the healing meniscus both in vitro and in vivo. Only small retrospective studies have compared meniscal repair with and without the application of PRP. One study found no between group difference in clinical outcomes scores, reoperation rate, or the proportion of patients who returned to work or sports. Another study reported no difference in reoperation rate or overall clinical outcome scores, but did find improvement in pain and sports parameters in patients who received PRP. Improvement in the MRI appearance of PRP-treated repairs also was reported. 0 of 17 control patients and 5 of 17 patients supplemented with PRP had a normal meniscus signal intensity. Collagen implant for patients with repairable meniscal injury and substantial meniscal loss, synthetic scaffolds may provide a new treatment option. A composite type 1 bovine collagen glycosamino-glycan scaffold was found to support the formation of meniscus-like tissue when attached to a meniscal rim. The scaffold was infiltrated by synovial and or vascular derived cells and replaced by host meniscus-like tissue. Long-term clinical data are promising. A retrospective review that patients treated with collagen meniscal implants for an irreparable medial meniscal tear had better clinical, radiologic, and functional outcomes at 10-year follow-up than patients treated with partial medial meniscectomy alone. So this retrospective review found that patients treated with collagen meniscal implants had definitely a better outcome than patients with partial meniscectomy alone. A prospective cohort study of 33 patients compared a medial collagen meniscal implant with a partial meniscectomy. At an average of 133 months, follow-up patients who received the medial meniscal implant had substantial better visual analog pain scores, as well as significantly higher functional outcomes as measured using the Tegner Activity Level Scale, International Knee Documentation Committee, Subjective Knee Evaluation Form, and Medical Outcome Study, item short form health survey scores. Patients with an irreparable lateral meniscus tear or a history of partial lateral meniscectomy also had substantial improvement in clinical outcome scores at 2-year follow-up with no progressive cartilage degeneration. So in a prospective randomized study of the use of collagen implants, patients with no history of surgery and patients who had undergone previous meniscus surgery received a collagen scaffold implant or a partial meniscectomy. Patients who received the collagen implant had significantly increased meniscal volume at a second look arthroscopy compared with the baseline. Patients with a history of meniscal surgery gained 42% of lost activity 5 years after collagen scaffold implantation, which was substantially more than those who received meniscectomy alone. An acellular biodegradable synthetic polyurethane scaffold has been developed for medial and lateral meniscal defects. This scaffold is highly porous and allows vascular and fibrochondrocyte ingrowth. In animal models, there was vascular ingrowth and matrix deposition onto the scaffold at 2 weeks, and by 3 months, the pores were filled with fibrovascular tissue. At 2-year follow-up, patients who were treated with polyurethane scaffold for post-meniscectomy syndrome after medial or lateral partial meniscectomy had significant improvement in all clinical outcome scores, and 92.5% had stable or improved International Cartilage Repair Society cartilage status. So I will tell you, all these you should look into, and even going into meniscal allograft transplantation. Let's come and see briefly what is the benefit. Meniscus replacement with allograft tissue appears to be a viable treatment for patients younger than 50 years with pain and dysfunction from meniscal pathology warranting subtotal or total meniscectomy. A biomechanical study found that meniscal allograft transplantation restores normal knee contact mechanisms and restores strain on the ACL with anterior translation to baseline. The described techniques include arthroscopically assisted and open procedures, as well as methods of fixation, such as transplantation with bone plugs attached to the anterior and posterior horns, a common bone bridge attached to both horns, and suture fixation only. This is showing you of how you can insert an allograft. This is a medial meniscus allograft transplantation using bone plugs, and lateral meniscus allograft transplantation using bone bridge secured to capsule through transosseous tunnels and peripheral sutures. 3 to 4 year outcomes were reported for medial and lateral meniscal allograft transplantation in patients with or without a history of meniscal surgery. After meniscal allograft transplantation, patients had substantial improvement in clinical outcome scores on the mean Lisholm scale. 77% of high school and higher level athletes were able to return to sport activity. Based on second look arthroscopy, MRI, 81.8% of patients had a satisfactory outcome. Midterm follow-up of arthroscopic assisted meniscal allograft transplantation also found promising results. Patients had improvement over baseline scores on the knee injury and osteoarthritis. Outcome scores, subscores for pain, other symptoms, activities of daily living, sports activity, and quality of life, as well as the visual analog pain scale. Medical outcome study, short form 36, and Lisholm scores. Long-term follow-up on open meniscal allograft transplantation using cryopreserved allograft found a 29% failure rate. Short-term outcome scores were better than baseline scores, but deteriorated at long-term follow-up. The most important factor determining outcome was the extent of concomitant articular cartilage degeneration. Better results were reported in patients with minimal degenerative changes. In summary, for meniscus, the menisci have been shown to provide load distribution, lubrication, and both translational and rotatory stability to the knee joint. Studies showing an increase in contact pressure on the articular cartilage and increased strain on the ACL following subtotal meniscectomy or high-grade radial tear have led to an increase in the number of meniscal repairs performed to preserve the load absorption and stabilization properties of the menisci. Clinical and radiographic healing rates of 60 to 85% are reported after repair. Meniscal repair with concomitant ACL surgery leads to a higher rate of healing than isolated meniscal repair. Tears repaired in smokers and tears larger than 20 millimeters have a lower rate of healing. Irreparable tears and post-meniscectomy pain syndrome are common in young patients and are difficult to treat. Collagen scaffold implants and synthetic polyurethane scaffolds have had promising results in animals and human studies for filling large defects after partial meniscectomy. Relatively young patients who undergo total or subtotal meniscectomy as a primary procedure may be candidates for meniscal allograft transplantation. Biomechanical studies found that strain on the ACL is reduced and knee kinematics and contact pressures are improved to near baseline levels after transplantation. The take-home message: the menisci are important load distributing and stabilizing structures in the knee. Repairs of tears in the red zone and pairs with concomitant ACL reconstruction are the most likely to completely heal. Results of meniscal scaffold implantation and allograft transplantation have showed promising results. Now we come to the next, which is non-arthroplasty management of osteoarthritis of the knee. We will carry on, but let me only rest my voice for 2 to 3 minutes, and thank you.
الدكتور جون أخذ ريست يخلص ويرجع يكمل المحاضرة.
Yalla, are we ready?
أوكي دكتور.
يلا. I rested my voice لما بقى في احكي. Non-arthroplasty management of osteoarthritis of the knee. يلا هاي. وفي مسجد. العادي اللي فرجي اياها وقولي له يحكينا على التليفون بس ليكي حسب ياخذوا مسكن بالشارع. ايه اوكي ready. Sorry, but I have to solve a certain problem. Osteoarthritis of the knee. نشوف لأن هيدي الأسود جاي عظيم. هيدي السوداء طالعة بوجهي ما بعرف. Osteoarthritis of the knee is a common source of pain and disability in adults who are middle-aged or older. كلنا بنعرف لما كان عندنا نشاف بالركبة يجي المريض عم يشكي من وجع بقلب الركبة. أوقات we get patients who are at a younger age. They are sports players and they have degeneration of the cartilage. And the biggest problem is what to do for them. According to 2008 estimates, knee osteoarthritis affected 33% of people older than 65 years in the United States. Lifestyle changes such as weight loss and exercise, as well as medications, injections, and in some patients, joint preserving surgery can help minimize the progress of knee osteoarthritis. We have to manage the pain and try our best to delay the need for joint arthroplasty. These patients are young. The majority are at a younger age, and they want to play it very active in sports and so on. You have to think of all these. Patient evaluation. The history and physical examination. The evaluation of symptomatic osteoarthritis of the knee begins with a detailed patient history and physical examination. The patient's symptoms and response to previous therapy will help guide future treatment and allow inaccurate prognosis to determine the management. You need the following current information. You have to know what medications the patient was taking, whether there was a history of previous injury, what kind of instability is present, does the patient have any mechanical symptoms, what about his medical comorbidities, what about the location of the pain, which is unicompartmental or global, and the response to previous treatment, swelling and symptom duration. A patient who is overweight should be asked about any recent weight gain or loss and current weight maintenance strategy, a comorbidity such as renal or peptic ulcer disease, and social factors that could affect the treatment strategy, such as residence in a nursing home, also should be determined. The patient's gait, as well as lower body alignment, the range of motion, the ligament stability should be assessed and documented. Catching or locking instability or an effusion can signal the presence of a mechanical pathology warranting surgical treatment. Lumbar spine and hips should be examined because pathology in one of these locations often appears as pain referred to the knee. The lower extremities should be examined for evidence of muscular atrophy or weaknesses, with particular attention to hip, abductors, and quadriceps strength. Distal sensation and vascular perfusion, peripheral pulses should be assessed in all patients, and any abnormalities should be documented. Baseline weight-bearing radiographs should be obtained in all patients with symptomatic osteoarthritis of the knee. Again, I repeat, you should take all the views that I mentioned about previously. The flexion view allows better evaluation of the posterior femoral condyles, namely the Rosenberg view or the Shoes view, and earlier detection of subtle joint space loss than the AP view. Additional radiographs, as I mentioned, were the Merchant views, Sunrise view. Now, all these views are taken to arrive to as such. One should take a standing AP and 45-degree flexion PA weight-bearing view, which is known as the Rosenberg view. Radiographs of the patient with osteoarthritis, where or left posterior lateral condyle can be seen. This is shown in the section on B. You see the degenerative processes that are occurring. The patient has an osteoarthritic knee on the left side. The right side, on the right-hand side, you have some narrowing of the joint on the other knee, but not completely narrow. You can see these points. And these are more apparent on the Rosenberg views. Non-surgical management, weight loss we spoke about, maintenance of a healthy body weight is effective for decreasing the severity of symptoms and showing the progression of osteoarthritis of the knee. Obesity has been identified as an independent risk factor for osteoarthritis of the knee. It increases the likelihood of symptomatic disease as much as threefold. Patients with coexisting knee malalignment, particularly genu varum, have an even greater susceptibility to the negative effect of excessive body weight. A clinical practice guideline of the American Academy of Orthopedic Surgeons recommends weight loss for patients who have symptomatic osteoarthritis of the knee and are overweight. This is defined as body mass index above 25 kilograms. You have to think of this as being a heavy load, a heavy weight, an obese patient. And one should look at this table and see all the modalities used other than surgery for the management. I believe in this table very much, and I would advise everyone to have a copy of it. Forces at the knee are magnified to 3 to 7 times the actual body weight, and therefore even a small change in body weight can have a significant effect on joint loading at the knee. At a minimum, the patient who is overweight should strive to lose 5% of his or her current body weight and maintain the decreased weight with a combination of diet and exercise. Exercise and activity. Regular physical activity was found to improve physical function and quality of life in patients with symptomatic osteoarthritis of the knee. The American Academy of Orthopedic Surgeons strongly recommends patient participation in self-management program such as Arthritis Foundation exercise program. Such programs extend over 6 to 8 weeks and are offered at a local hospital or community center and focused on lower extremity and core musculature strengthening, low-impact aerobic activity, neuromuscular training. All this is fit into a single program of how one should avoid surgery at the young by build-up and by build-down as far as weight is concerned, build-up as far as exercise. There is a special program given in the United States within the hospital. Patients receive information on activity modification, healthy eating, stress management, and disease progression. General activity recommendations for patients with osteoarthritis of the knee include avoidance of high-impact activities and repetitive heavy lifting, squatting, or crouching, or climbing. Patients can safely undertake at least 150 minutes of moderate activity each week with no risk of worsening the disease progression. Activities such as water aerobics, walking, swimming, cycling, and Tai Chi can increase cardiovascular endurance, lower extremity strength, mobility, and balance with minimal impact on the knee. Physical therapy, a patient with sedentary or has a persistent deficit in strength or mobility after completion of a self-management program can benefit from a course of prescribed physical therapy. Extensive mechanism weakness is common in patients with symptomatic osteoarthritis of the knee and has been associated with exacerbation of symptoms and disease progression. Therapists should do supervised exercises, special physical therapy to build up the muscles about the knee that give you the dynamic stabilization of the knee. All these should be built up. Bracing, the routine use of a brace is not recommended for managing the symptoms of osteoarthritis of the knee, but in some patients, the use of an unloaded brace was found to decrease pain and improve function. According to the 2013 AAOS appropriate use criteria, treatment with valgus or varus producing unloader brace may be appropriate for a patient with symptomatic unicompartmental medial or lateral osteoarthritis, respectively. Unloader braces exert an external movement at the joint during gait. I will show you what this is like. This is an unloader brace. If the patient has pain along the medial joint line, wearing this brace will take the stress, or it creates a less load on the medial aspect of the knee joint, and the patient's symptoms are much less. A biomechanical study found that the greatest load reduction occurred during stair ascending and descending. An unloader brace can be helpful for an active patient who wants to delay surgical treatment, meaning osteotomy or an arthroplasty. Pain relief during a trial of brace wearing was found to predict a favorable outcome of realignment osteotomy. Medial side disease was found to be more responsive to bracing than lateral side disease, meaning medial tibial plateau degeneration. Bracing can be effective in the setting of fixed deformity, but most brace manufacturers recommend bracing only for patients with no more than 10 degrees of varus or valgus deformity. Instability, especially excessive medial or lateral collateral laxity in the affected compartment, is a contraindication to unload the bracing. So they should be stable. Don't forget this, to use this brace. Concomitant arthritis of the patellofemoral joint is not considered a contraindication. Custom braces were found to be slightly more effective than off-the-shelf braces, and a custom brace may be required to achieve the desired fit and force generation for a patient who is obese. Patient tolerance is one of the main limitations of the unloaded bracing. The load distribution depends on the stiffness and angulation of the brace, and the brace specifications required to achieve a load reduction of more than 25% are not well tolerated by most patients. Taping and insoles. Taping can be helpful in managing the symptoms of patellofemoral osteoarthritis. The use of taping technique, such as McConnell taping, generates a medially directed force across the patella and provides short-term pain relief and improves function. The use of a lateral heel wedge insole for symptomatic medial compartment osteoarthritis was not found to be effective and is not recommended. Alternative treatment. You can use acupuncture. Some there was a good response, some a poor response. Electrical stimulation, likewise. The risks and benefits of manual therapy and ultrasonography have not been established. Medications, of course, non-steroidal anti-inflammatory drugs are used. Acetaminophen is used. Tramadol, opioids, nutritional supplements, ginger and avocado have been found to be successful in the management of some patients, not all. Injections, corticosteroids. Intra-articular corticosteroid injections is effective for managing the symptoms of osteoarthritis of the knee. And the American Academy of Orthopedic Surgeons considers it to be an appropriate treatment option. Corticosteroid injection can be helpful treatment adjunct after unsuccessful non-pharmacologic or oral non-steroidal anti-inflammatory drug or analgesic therapy. So, steroids are helpful. We don't like to give more than two injections per year, and they are temporary. Every 3 months is the maximum you can give it. Hyaluronic acid is claimed to be useless. They say it is not effective by many authorities. The benefit of intra-articular hyaluronic acid remains debatable. Several studies found that visco supplementation led to a statistically significant improvement in pain, but recent analysis, including evidence-based review of the AAOS, suggested that the treatment with hyaluronic acid did not meet the threshold for a minimum clinically important difference. Reliance on this criterion as a primary metric for treatment efficacy is controversial. So this is very controversial. And the effect of intra-articular hyaluronic acid probably depends on several factors, including the severity of the osteoarthritis, the patient's age, and the limb alignment. In a comparison of intra-articular corticosteroids and hyaluronic acid injections, corticosteroids appear to be more effective in alleviating pain during the first 4 weeks after injection, but hyaluronic acid was more effective beyond 3 weeks after injection. A recent systematic review reported a small and clinically irrelevant improvement in pain, a small and irrelevant appearance of pain after hyaluronic acid injection, as well as a significant increase in the risk of serious adverse events, including a post-injection flare reaction. In addition, corticosteroids to a viscosupplementation injection was found to decrease the post-injection pain associated with viscosupplementation alone. So you use them in combination. Practitioners should exercise clinical judgment when considering this treatment modality by weighing the potential for improving the patient's pain against the risk of adverse events. Growth factors, platelet-rich plasma. The benefit of using growth factors or biologic agents such as platelet-rich plasma or mesenchymal stem cells in treatment of osteoarthritis has not been established. In theory, these agents provide biologic stimulation for articular cartilage maintenance and possibly repair. A systematic review of level 1 and 2 studies found a short-term, 6 months beneficial effect of PRP treatment on subjective outcomes in patients with mild to moderate osteoarthritis, but the risk of nonspecific adverse events was increased. A randomized controlled study comparing treatment with PRP and treatment with hyaluronic acid found no significant between group difference in patient-related outcomes at 12 months follow-up. Subgroup analysis revealed a trend toward better patient function after PRP treatment in patients with mild osteoarthritis, namely Kellgren-Lawrence grade 1 or 2. So this is something you should know of. The rate of adverse reactions, particularly post-injection pain, was higher in patients who received PRP than those who received hyaluronic acid. So these treatments are all carried out. It's surprising that some patients benefit tremendously from one type of injection, while others don't. And they could have the same amount of osteoarthritis, either grade 1 or grade 2 osteoarthritis. So it varies. But all these treatments tend to improve the patients somewhat. What about the surgical treatment? This is our interest. Arthroscopic debridement and lavage. Arthroscopic debridement and lavage of the knee is not recommended for a patient with a primary diagnosis of osteoarthritis. One high-level study found no benefit to using this treatment modality. And I'll tell you, in certain patients, following this treatment, they ended up having an osteonecrosis of the medial femoral condyle for reasons we don't know much. In patients with mechanical symptoms, secondary to the presence of a loose body, knee arthroscopy with loose body removal may be beneficial, especially if the patient has mild to moderate osteoarthritis. Arthroscopic meniscectomy, the effectiveness of arthroscopic partial meniscectomy for patients with osteoarthritis of the knee and a concomitant meniscal tear remains an area of debate. In a randomized controlled study comparing partial arthroscopic meniscectomy with physical therapy and intention to treat analysis found no between group differences in patients' rated outcomes at 12 months follow-up. There was a 35% crossover from physical therapy group to the surgery group, however. A second randomized controlled study compared arthroscopic partial meniscectomy with diagnostic arthroscopy and found no difference in patient rated outcomes at 12 months follow-up. So, exclusion of patients with traumatic meniscal tears, lateral tear, and acute tear, acute on chronic tear, or radiographic evidence of osteoarthritis limited the relevance of the study results for the general population of patients with osteoarthritis of the knee. So I'll tell you, there is much argument, and realignment osteotomy is becoming more or less popular. The argument is between open and closed high tibial osteotomies, and the knee malalignment is a known risk factor for the development and progression of osteoarthritis. Realignment osteotomy rarely is indicated, but can be considered for a patient who is active, younger than 55 years and not obese, and who has moderate varus or valgus deformity, mild to moderate unicompartmental disease, stable collateral ligaments, and a near normal range of motion. So we can do this, but there are contraindications which are relative or absolute. If the patient is obese, we don't like to do osteoarthritis. Moderate to severe osteoarthritis of the knee, the age older than 50, patellofemoral arthritis, and collateral laxity. These are relative, but the absolute are contralateral compartment osteoarthritis when the osteoarthritis is generalized, flexion of less than 100 degrees, flexion contraction of more than 10 degrees. All these should be taken into consideration. So actually, high tibial osteotomy has been quite helpful. You have quite a number of people doing this in the past from Coventry onward, and they claim to have a good result, but as the year goes on, and with years, the amount of improvement declines. And by, let's see, what age they claim. This is an open osteotomy, and I'll tell you, these are good, and they give symptom relief. But you should realize one thing, that with time, the rate of improvement declines. And the trend nowadays is to do an open biopsy and to correct the deformity. I'm not going to go through this. For instance, at 5-year follow-up, the medial opening wedge technique was associated with more post-operative complications, but 14% fewer conversions to total knee arthroplasty than the lateral closing wedge technique, 3 months versus 3% versus 11%. So you have to pay attention to this. And the medial opening wedge technique is more sensitive to sagittal plane. You have to pay attention to the slope, the posterior slope. You should not increase the posterior slope. This would increase the strain on the ACL and the results would decline. You have to pay attention. And where you put your plate, it's very important. If you put your plate too anteriorly, you see that the slope increases. If you put it too posteriorly, you decrease the slope tremendously. And if you put it in the center, your plate, when you're doing your osteotomy, your open osteotomy, you won't change the slope. So you have to pay attention to this. The overall survivorship of a high tibial osteotomy for medial compartment disease was found from a range from 88 to 96% at 5-year follow-up. Then you go down from 63 to 97% at 10-year follow-up, and from 57 to 90% at 15 years. So it tends to drop. But actually, you're giving the patient time without a prosthesis. And especially if he wants to stay in active sports. Neither medial nor lateral high tibial osteotomy affected the functional outcomes or survivorship of subsequent total knee arthroplasty. In patients with lateral compartment disease and valgus deformity, a lateral opening wedge distal femoral osteotomy can be used. The outcome of varus producing osteotomy appears to be less affected by concomitant patellofemoral osteoarthritis than patients with medial compartment arthritis undergoing a valgus producing osteotomy. A 50% conversion rate to total knee arthroplasty was reported within 15 years. So pay attention to this. The improvement declines with years. 50% conversion rate to total knee is at 15 years. In summary, the non-arthroplasty treatment of symptomatic osteoarthritis of the knee is a common clinical challenge. Patients may experience substantial pain and disability. Lifestyle modifications, including weightlessness and exercise, as well as use of non-steroidal anti-inflammatory drugs or intra-articular injections, can reliably decrease pain and improve function. The role of biologic therapies such as PRP is under investigation. In selected patients, non-arthroplasty surgical procedures such as realignment osteotomy can help alleviate symptoms. In the absence of mechanical symptoms, arthroscopic debridement has not been shown to be an effective treatment. The take-home message: a variety of non-surgical treatment modalities can be used to treat the symptoms and decrease the progression of symptomatic osteoarthritis of the knee. Weight loss for patients with a body mass index above 25 is effective in decreasing pain and minimizing the progression of symptomatic osteoarthritis of the knee. Intra-articular corticosteroid injections are effective for symptomatic management of osteoarthritis of the knee. Oral supplementation with glucosamine for chondroitin sulfate has no benefit for management of symptomatic osteoarthritis of the knee. Continued study is needed to identify the benefits of PRP and stem cell therapy in the treatment of osteoarthritis of the knee. In the absence of mechanical symptoms, knee arthroscopy with debridement is not effective and, as a matter of fact, harmful in treating osteoarthritis of the knee. Now, the last disorder is leg pain. I'm going to go through it very quickly because I've got to finish this program today. I'm sorry. I am bored as much as you. So the topic today and now is leg pain disorders. Exertion-related leg pain is common among people who are physically active. As many as 80% of collegiate athletes seek health care for leg pain. Leg pain can present a clinical conundrum because the symptoms of several disorders are similar, and a meticulous workup is required to reach the correct diagnosis. Medial tibial stress syndrome, stress reaction, fracture, chronic exertional compartment syndrome, and popliteal artery entrapment syndrome should be considered in the differential diagnosis. Recent research has examined the clinical characteristics, risk factors, diagnostic modalities, treatment options, and outcomes of conditions causing leg pain. Let's speak about medial stress syndrome. This is an interesting topic because we all have had this number of patients coming to us. It is often called shin splints and is a common cause of leg pain. The incidence in athletic and military populations is 20 to 44%. I repeat, 20 to 44%, you see it in people who are doing athletics. The medial tibial stress syndrome is characterized by pain on the medial border of the tibia, typically near the origin of the soleus, posterior tibial tendon, and flexor digitorum longus. You see patients on the field squatting and palpating their leg from pain. This posterior medial pain has led some authors to conclude that traction of these muscles leads to an encephalopathy, periostitis, and pain. However, in some patients, dual energy X-ray absorptiometry and CT reveal relative osteopenia of the anterior tibia. This finding suggests that MPSS is on a spectrum of tibial stress injuries that includes tendinopathy, periostitis, periosteal remodeling, and tibial stress reaction. Pain with palpation and the presence of edema are highly sensitive for this spectrum of disorders. Although MTSS is common in running and jumping athletes, the pool of at-risk individuals has been expanded. A prospective study of naval recruits found that MTSS was twice as likely to develop in women as in men. Excessive pronation of the foot was found to be a key risk factor in 2 biomechanical studies of foot posture during walking and running. Patients with MTSS had greater medial longitudinal arch deformation while walking or standing than healthy control subjects. Early heel rise, forefoot abduction, and a propulsive gait were significantly different in patients with MTSS. Relatively small internal and external hip range of motion, high body mass index, lean calf girth, as well as a history of MTSS also have been identified as risk factors. Anthropometric parameters, including thigh length, leg length, foot length, leg circumference, as well as limb length alignment, had no association with the MTSS. Individuals who had participated in an athletic activity for fewer than 5 years were found to be substantially more likely to have MTSS than those who had participated for a longer period of time. Recovery from injury was defined as absence of pain in the affected anatomic location after 2 associated sessions of running at least 500 meters. In a study of Dutch military recruits, the average time to recovery was 58 days. Most treatment regimens consist of active rest, followed by a gradual return to running, which begins only when low-impact activities such as walking or cycling produces no pain. So return to running programs vary. Implementation should be gradual. Running distance should increase no more than 10% per week and should be immediately decreased if symptoms return. In a randomized controlled study, no benefit was found to adding calf strengthening and stretching or the use of compression stockings to return to running program. Rehabilitation taping was found to decrease loading of the feet in patients with MTSS, although it did not relieve the symptoms. Using a foot orthosis was found to be helpful during a 3-week study period. Pain was reduced by 50% in 15 of 20 runners with MTSS, but this effect might have been produced by rest alone. Low energy extracorporeal shock wave therapy was found to be a treatment option for patients with MTSS of more than 6 months duration. SWT is believed to induce periosteal detachment and microfractures of the trabeculae, which can stimulate healing. At 15 months, follow-up of 47 patients with chronic MTSS who underwent extracorporeal management. In addition to a home therapy program, 40 had returned to sport at the pre-injury level. Comparison, only 22 of 47 patients who underwent home therapy alone had returned to pre-injury sport level. What about the tibial stress reaction? On spectrum of tibial stress disorders, the severity of tibial stress reaction is between that of MTSS and tibial stress fracture. Radiographs may show a periosteal reaction and cortical thickening. An MRI study identified a progression of injury from periosteal edema to progressive bone marrow involvement and ultimately a cortical stress fracture. So, if you want to grade them by MRI, there is a specific grading, can vary from normal MRI findings to mild to moderate edema on T2, have severe periosteal reaction and bone marrow edema on T2 weighted images. 3 is a moderate to severe edema and bone marrow T1 and T2 weighted images are elevated. Low signal fracture line on sequence, and you can have severe bone marrow edema on both T1 and T2 weighted images. So these are stages of dividing this. Osteopenia in the anterior cortex of patients with MTSS also may be part of the progression. The etiology is believed to be inadequate bone remodeling after damage. And you can see a theoretic cascade from the onset to a complete bone fracture. And this slide is an algorithm of what happens. Tibial stress reactions often are asymptomatic. A study of 21 collegiate long-distance runners who were asymptomatic found that 9 had grade 1, 2, or 3 MRI changes indicative of a tibial stress injury. None had grade 4 changes. 5 patients had bilateral involvement. The most common finding was severe periosteal edema and bone marrow edema with T2 weighting, as is consistent with grade 2 injury. None of the patients became symptomatic during the subsequent year. This study highlights the value of clinical history and physical examination in treating a tibial stress reaction. So, this shows the common causes and locations of exertional related leg pain. You can have a chronic exertional compartment syndrome. You can have a popliteal artery entrapment syndrome, and you have the medial tibial stress syndrome or tibial stress reaction or a tibial stress fracture. This is the differential diagnosis of leg pain. Look at it. Popliteal artery entrapment, chronic exertional compartment syndrome, tibial stress syndrome, tibial stress reaction, and tibial stress fracture. This gives you the differential diagnosis of leg pain. And tibial stress fracture is shown over here of how the sequence is. Stress fractures are the most severe bone stress injury. The history and physical examination are characteristic, and the diagnosis is made with radiographs, CT scans, bone scans, and MRI. Approximately half of all stress fractures occur in the tibia. The reported incidence of tibial stress fractures was found to range from 4 to 20% based on the population. Those at risk typically include long-distance runners, track and field athletes, jumping athletes, military recruits. A year-long prospective study of elite military recruits found that almost all tibial stress fractures occurred during the first 6 months of training. In contrast, stress fractures of the metatarsal were most likely to occur during the second 6 months of training. Stress fracture, as well as the mediotibial stress syndrome in women, are associated with low bone mineral density, low body mass in the lower extremities, menstrual imbalance, and a low-fat diet. The Female Athlete Triad Coalition and the International Olympic Committee recently proposed guidelines for the evaluation of risk factors, treatment, and return to play for at-risk female athletes. The Female Athlete Triad Coalition consensus statement includes a scoring system for an athlete's diet, body mass index, the age of first menarche, menses, regularity, bone mineral density, and previous stress fractures. The resulting score can guide the physician in deciding whether the athlete should be returned to play. The International Olympic Committee guideline is similar to that. It includes many aspects of the athlete's health by calculating the so-called relative energy deficiency. So you have to think of this. So a similar model has been created for predicting the risk of stress fracture in military recruits. So I'm going to go very quickly because I think I overpassed my time. The important point is to know the differential point between this. There is only one syndrome that I haven't discussed, where the gastrocnemius and the vessel that is supplying the lower extremity, the popliteal artery, it is squeezed between it and the condyle, between it and the tibial plateau, between it and the muscles. So when they apply force, the muscles hypertrophy, they squeeze the popliteal artery, and as a result, these patients will have signs and symptoms of pain and insufficiency of circulation in the area. So this is one of the entities we have to add to all these medial tibial stress syndrome, and not forgetting the exertional compartment syndrome that we get on sports, which is temporary, then he's on rest. So you have to pay attention about this. Let me see if recent research has emphasized the importance of calcium and vitamin D homeostasis in preventing and treatment of stress fractures. Pay attention to this. High levels of circulating parathyroid hormone with subsequent bone turnover is established. Risk for osteoporotic fractures and a high parathyroid level may be an independent risk factor for a stress fracture. So pay attention to this point. Now let me see if I have anything to add. Modalities such as pulsed ultrasound have been proposed for managing stress fractures. Although the exact mechanism of pulsed ultrasound is unknown, it is believed to induce aggrecan and proteoglycan synthesis in chondrocytes leading to increased endochondral ossification. However, in randomized double-blind study, 43 patients with tibial stress fracture were assigned to pulsed ultrasound or placebo treatment, and there was no significant between group difference in healing time. Further study of this modality is needed. So we have to pay attention to this. Let me see if there's anything I would like to mention. Non-union rates, I would just like to mention briefly about it. That these fractures are very difficult to heal. Non-union rates are higher than 60% and healing delayed as much as 11 months have been reported in these medial tibial stress fractures. And you have to pay attention to this. They are very difficult to treat. We like to, when there is signs of edema and all the signs that the fracture could occur, it's better to treat them before the fracture, because these do not unite easily. So what do? We put intramedullary nailing, but this is not enough. You have to put an associated plate. A plate should be put in association with a nail. The theoretic advantage of this technique over the use of an intramedullary device is that the plate placed anterior to the central axis of bone has a mechanical advantage in neutralizing tensile forces and fracture micromotion. These are plates. Full healing and return to activities was reported at an average of 10 weeks to 3 months after surgery. Drilling and anterior laminofixation also were reported with healing rates of 50% and 93%. So you have to know about this. Chronic exertional compartment syndrome, I just would like to mention something briefly. I hope I have put a summary on this. And this is the popliteal artery entrapment syndrome that we haven't discussed. Let me see, in summary. The spectrum of tibial stress disorders can be distinguished by history and examination and imaging. Non-surgical management usually allows patients to return to their earlier activity level through prolonged rest, often is needed. The widely used Pedowitz criteria for diagnosis of chronic exertional compartment syndrome may have a high false positive rate. A walking treadmill test on an inclined surface while carrying a 50-kilogram weight may have better diagnostic accuracy. See, the problem, these patients come to you, they don't always have pain. It's only when they're during sports. And actually, you have to do various studies to surgical release of the compartment affected by chronic exertional compartment syndrome has been the treatment of choice. Let me tell you this. We had a resident. A resident had a small gap in his forearm. And every time he would do sports, this gap would increase. This resident went to an outside hospital and saw a plastic surgeon. The plastic surgeon told him, you have a hernia. And he operated on him and he closed this hernia. What happened? What happened is he became completely developed a compartment syndrome. And all the signs of contracture occurred in his forearm. One should never close defects. As a matter of fact, when one is doing sports, as he is doing sports, there can be certain tears in the fascia. and hernias of muscle might come out. But this is a sign that the compartment is too tight. One should never close the compartment. If anything, it should release the compartment fully so as to obtain a complete release for these chronic exertional compartment syndromes. Decompression alone is often enough if diagnosed early, and bypass grafting is often needed in the chronic setting. Take-home message. MTSS, tibial stress reaction, and tibial stress fractures are overuse disorders that particularly affect women, endurance athletes, and military recruits. The keys to preventing stress fracture include adequate dietary consumption and calcium vitamin D. Non-surgical management usually allows patients to return to their earlier activity level, although prolonged rest often is needed. Surgical intervention for medial stress syndromes of the tibia can be considered for a patient with recalcitrant stress fracture or a high-risk fracture of the anterior tibia to an athlete who needs to return to sports quickly. Current diagnosis criteria for a compartment exertional compartment syndrome, use of IMCP, and can lead, meaning is a direct or an IMCP can lead to high rates of positive results. Criteria using improved standardized exercise testing may have greater sensitivity and specificity. Surgical release successful for chronic exertional compartment syndromes, but may not lead to return full sports activity or active military duty. Early detection and treatment of a popliteal artery compression or condition are critical for preventing chronic vascular disease and relieving symptoms. So I thank you. Really, in the very end, it had been bothersome to try and finish this lecture. I tried my best to finish it, but I would like to add two things. You have to know about chronic exertional compartment syndrome, and you have to know about popliteal artery compressions. When the artery is compressed between the condyle and the muscle, and in this, when you're doing sports, this would lead to ischemia of the lower extremity. And therefore, you have to release this if it happens. You have to make the diagnosis and release the pressure on the artery. While in chronic exertional compartment syndrome, it might be difficult to diagnose, but many symptoms, signs you could have, such as a hernia in the muscle of the leg. Be very careful. Okay? Thank you very much. نعم.
دكتور جون. شكرا لك، تعبناك، صوتك اليوم
احترق ديني بهاللكشة.
ايوه
4 ساعات، الله وكيلك.
الله يعينك يا دكتور ويعطيك الصحة والعافية، معلومات رائعة وكل شيء جمعتها لهم للشباب. تمام.
ليك بدي اقول لك شغلة خالد. الارثروسكوبي انا بنصحهم اذا بحبوا الارثروسكوبي لازقوا او they say stick to in arthroscopists and get the details of each. مش كل واحد تعمل له arthroscopy وتبلش تعمل له تنظيف بالركبة، لأن they have to know that they can have complications from it. They can have complications from removal of a partial meniscus tear. They can have complications even from repairing a meniscus. They have to go more into arthroscopy. أنا مش عامل arthroscopy. أنت عامل خالد؟
لا أنا ما عندي interest بالارثروسكوب.
أنا have no interest because يا خي بتشغل الراس بعمرنا. أنا بعمري أنا. بقول لك it's difficult. ما بعرف بعمرك أنت. بس انا بعمري ما لي خلق
انا ما
على
لي
الأرض.
كثير، واحنا يعني زي ما انت قلت دكتور جون، الليرنينج كيرف لازم يكون موجود في حالات الارثروسكوبي ضروري، يعني لازم
انا بدي
يتعلموا
اقول
يعني.
لك خالد بليز ستريس لكل يلي حضروا انه they should know the differential diagnosis of pain in the leg. لازم يعرفوا شو هن الخمسه conditions اللي بيعملوه. البوبليتيال artery they should know of it. They should know of the management. They should also know about chronic exertional compartment. بس كمان نحن عاملين رح اقول لك خالد مش بوقتك بوقتك كنا نجيب واحد عنده هيرنيا بالفور ارم او باللاج، بنقول له شو بتعمل له؟ بتقطب له اياها. اذا قال له انا بقطب له اياها، ليش لا؟ ساعتها كنا نسقطه.
صحيح.
ليش؟ لان مجبور يفتح الكومبارتمنت وما يقطبها. These are points to mention about the leg. فهمت كيف؟ about the meniscus لازم يعرفوا generalities اللي اعطيتهم اياها، شو الفانكشن تبع المنسك، شو التريتمنت، وهيدي اكثر من هيك ما بقدر.
لا واضح انت جمعت لهم كل شيء.
اوكي حبيبي،
شكرا لك.
have a good day.
ثانك يو.
يلا باي.
يو تو.
لبعد جمعتين
ان شاء الله.